Hello, everybody. It's very nice to be here. I am Miccio, CEO of People USA. And just to let you know, we are a peer-run mental health organization. We were born out of the human rights movement when psychiatric centers were closing in New York, and people with lived experience were being released from the hospital, the psychiatric hospital, and they started voluntary advocacy and support groups in the community, and soon got their 501c3 not-for-profit status in 1990 and became an advocacy organization. And then we moved into services when I came on board in 1999. So we're going to talk about some of those services now. And again, I'm really glad to be here. All right, so the agenda will be just a quick introduction into more of who we are, the ideal system of crisis care. We'll move and talk about the sequential intercept mapping, the asset-based community development work that we've done, and then the outcomes in our peer-run programs that we provide. So again, I am Steve Miccio. I am someone with lived experience. Have been hospitalized, have been through the barrage of medications that have been tried on me, and different therapists, different psychiatrists throughout my lifetime. I can gladly say that I am no longer on any medication. I am also not in any traditional treatments or therapy. Peer support is my main mode of wellness, and then also working in this organization has been extremely healthy for me, in being able to help people in a non-traditional way, but also in partnership with traditional services. So again, very glad to be here. So People USA, again, was an advocacy organization first, will always be an advocacy organization, because unfortunately we still need to advocate in our world, so that people are treated with the dignity and respect that they deserve. We have crisis recovery and wellness programs, and we serve a bunch of counties here in New York State. In addition, though, we've helped to open a lot of different services across the country and in other parts of the world. Our main services that we're known for are the respite houses that we created 24 years ago, almost 25 years ago. I did that with in partnership with Sherry Mead, who was doing some respite house work in New Hampshire. And then I evolved it into a service that was easily accessible for everybody in our community. Within a couple of hours, you could be in the house. It depends on how far you live from the house. We changed language to pre-registration, registration. Everyone is a guest in our houses. And from designing the first one that I did, we've helped to open over 40 in the country and in the Netherlands, and some other countries we're now working with in opening more there. And it's a great model where people can come stay 1 to 7 days and be treated with dignity and respect, and also look at their crisis, talk about their crisis, look at the crisis differently, maybe offering education on how to avoid those crises in the future. But we also stay connected with everybody we serve if they want that. It's all voluntary. Every one of our services is voluntary. Our care coordination is case management, but it's now a Medicaid billable service, so they call it care coordination now. We've started that a few years ago, and that's been a good support for the organization, because it allows us to live in the values of peer services, but get additional income into the organization to do other services as well. We are a housing first organization, so we provide a lot of housing here in New York. Core services are peer services and psych rehab services that are now also billable, allowing us to again maintain our values as a peer-run organization, but also to get additional funding for the work we already do. So it's been helpful. Our peer support services, we have peer support in all of our services, peer groups. We do a version of mixers and nights out so that people can get out of their, if they're isolated, they can get out of their homes and experience socialization. We focus a lot on the 8 dimensions of wellness as well with everyone we serve, so that peer support services cover a lot of that. They are mobile. They are stationary in our facilities, but also mobile in the community if people can't get to us. We don't call it a mobile team, but we do call it mobility, mobility access for people we serve. We created the first Northeast Crisis Stabilization Center, and in fact, it is all peer run. We're since then opening 3 more in the next 8 to 12 months in the different counties that we serve. So we're continuing on with that, and with that, we included mobile services as well. And I'll talk more about the mobile services as we go forward. We also work very closely with criminal justice system and police departments and things like that. I am not a co-responder fan, but I am a fan of working with police departments to allow police officers to do their job while we come in and do our job in helping the people that don't need that criminal justice focus. We also provide all of the crisis intervention team training in our area to officers, so they get 40 hours of training on how to engage in a healthier way with people in our communities and also work with us. So we're building more collaboration and community focus on avoiding the criminal justice system with the police departments, then the different court systems as well. In our ideal system is that we've created has been our Rose House Respite, which is accessible 24/7, our Crisis Stabilization Center, and our mobile team, which we have the law enforcement assisted diversion team in Dutchess County that works right out of the stabilization center. And this is a team that gets contacted by the police that are out on the street, and they see somebody that they've seen for maybe years or for a long time, where they may have been disruptive to the community, but they're not people that are necessarily involved in the criminal justice system. They could be. The police choose not to. So they call the lead team. The lead team dispatches and goes out to the individual in the community without the police being present, and they engage. And these are all people with lived experience. We have clinical staff, we have peer specialists, we have staff, which are substance abuse specialists, and then certified recovery specialists too, that work in the substance use world, that work together, and they engage people and build the relationships with the people in the community. Even build relationships with the police if that's something that the individual wants, which generally they don't, but we will do that for an individual if they're asking for that. But it's a very successful service that we engage, and if they choose to work with us, we will use a whole cadre of services from the community to help them have a better outcome, better quality of life, the choice for a better quality of life. And we first started this team just started in March, and they already have 28 people, I think, that have agreed to sign on for services. So they are getting served almost daily by the lead team, with the lead team, and building wellness plans for each of them. And we're seeing some great outcomes already from them. So this is an ideal system that we created from a peer operated organization perspective. And the reason we did it is because we saw these gaps in our community, and we had the opportunity to close the gaps by creating these services. And it's just been something that's been building. The Rose House came first, like I said, 24 years ago. The crisis stabilizations came next, and then with that came the mobile team, which just made sense to infuse into the crisis stabilization center. Now, with this being said, we don't throw the baby out with the bathwater. We work with the traditional system of care as well. So we're working with other providers. We're working with the social service system. We're working with whoever else needs to work with us, whether it's in the substance use world or in the mental health world and the healthcare world. So it's important to remember that we have a whole health approach with the people that we serve, and in the when we're serving people, we're looking at the 8 dimensions of wellness, that the Sampson model, but we're also looking at whole health for the individuals, and we're finding a lot of comorbidity in health issues with our mobile teams, because these are folks that are not generally going for the services that they need or deserve in healthcare. And this team is connecting them to the healthcare world, which is we're finding just about every person has something else going on besides substance use or mental health, and they're getting them into the care that they need. So we work closely with the federally qualified health centers, if you can imagine. They become a great partner. In fact, they have a mobile SUV, or not an SUV, a trailer that they bring out, and they offer healthcare wherever the team might be set up in different events and things like that. So we got a great partnership going with the federally qualified health center. And in addition, we do have great relationships now with general practitioner organizations too, where we're working more closely with them. The Stabilization Center has wonderful relationships now with rehab and detox organizations, where they will actually come to the center to pick people up. We can deliver them to them through the mobile team, but we have access to getting people to the services that they need and deserve. We do this. So if you can't have everything or things that I've given you examples about, we have some examples of how we operate other mobile teams without a crisis stabilization center. The fortunate thing is that we started these mobile teams, and I'll speak to each one, but we just got approval recently to open another crisis stabilization center in these communities where we're running these teams. So now we'll be able to have both, where a crisis stabilization center and mobile. And in addition, we already have respite houses in these areas too. So we're putting again together the perfect, continuum internally for people that are dealing with issues in our community. So just a straight mobile crisis team is one that we have in one of the counties, where they are accessible 24/7, and they get a call. And the only thing I do different, and I know other people are doing this as well, is that we will respond within the hour to the individual. It's important for me, and in my own experience, to have immediate accessibility to services. And that's always been the struggle in some mobile teams. I know in New York City, the mobile teams down there have a long period of waiting before they can respond to somebody in the community, in the city. That to me wasn't acceptable. So we've created a team that can respond 24/7 within the hour. If they are engaged somewhere else at that point, we do have partner mobile teams in other areas of the county that we can call on to see if they can respond. And if they can't, we'll be on the phone telephonically, working with the individual until we can get the team there. But we use every means possible to respond as quickly as possible for them. The crisis stabilization team was an idea I had based on the Crisis Stabilization Center. So again, these are peer operated, peer run, but we do have clinicians on the teams that also have disclosed their own personal histories and lived experience too. And the crisis stabilization team is very similar to the mobile team. They are not 24/7 though. They do operate from 8 a.m. to 8 p.m. They they have access telephonically, again, 24/7 to our warm line services. So they do have somebody that they can talk to until the team can be dispatched, either in the morning or in the evening, whatever it is that they need the team to come work with them. They do focus on, again, some criminal justice work. They focus on going to the courts as well to do alternatives to incarceration with the judges. They work more on the care management side of things too, because we're working with a lot of homeless, a very large homeless population, and working on getting them transitional housing, transitional services, permanent services in the community. And as you can imagine, the training that has to go into every team, they have to know the community. And it's very important to understand what's going on in the community, what's available in the community, and who our partners are. So they will work with the individual as much as they can to stabilize them, because this is more of a crisis on the streets where an officer might be in the background. Our goal is to not have the officer in the background, but they might have to on certain situations. But mainly focusing and working with the individual. The peer forensic diversion team is one that works with the court system. So that's a team that is working after arrest with an individual to be dispatched and work with the court system on alternatives to incarceration, so that they can either get a reduced sentence or get an alternative to incarceration, or avoid any forensic interventions at all, and the charges can be dropped. So we're working with that team on after the fact, unfortunately, but at least we can work with them and tie them into our other services or other community services, so that they're not constantly rotating into the criminal justice to homeless to wherever, to crisis services or whatever. This team stays very engaged with people, as do all the teams. Stay very engaged with people that want that engagement and continued service delivery from them. So I can use other parts of my organization and department, in the peer services or wherever they might be needed, should we have to backfill some engagement or anything like that. So we're fortunately growing fast enough that we can meet a lot of those challenges, because we do get very busy with a lot of the people that we're serving. So we designed this model, which is a critical time intervention model, and it's New York State now funding it, and we have one team that we're actually working with, and on that team will be a peer specialist, a licensed clinician, a CASAC, which is a substance abuse counselor, and a care manager. So it's almost like an assertive community treatment team, but we just respond differently than the ACT teams, in that they're, again, critical time intervention to work with the individuals. They are certified. Our staff are all certified peer specialists or certified recovery specialists when they are on the team. And we are moving forward with this in areas of large homeless areas, where the team is going in and assessing what's happening in the community, what kind of services we can provide them directly, hands-on, and also what kind of services we can provide going forward with the individuals. And this is, again, another team that we've just developed and are just starting here in New York. So how do you make it successful? That's the challenge, is, you have to really map out your community and understand what's available in your community, what's not available in your community. Some of it might mean you have to create it. Some of it might mean that it's there, it's just not utilized. But you have to map your assets. You have to engage, the community and understand what is available. So, we work with universities, we work with chambers of commerce, we work with all different disciplines in our communities to understand how we can build relationships and map those assets, how we can mobilize development and information sharing. And we use a process called appreciative inquiry, where you can have a large group of people with a couple of facilitators asking specific questions of a group, and you can, I've seen up to 5,000 people in a facilitated session, and it's broken up into groups answering questions, working with all the different disciplines in the community to figure out how do you map a community where it's going to be an asset to the people that are being served. It goes beyond social services, like I say, it goes beyond academia, it goes beyond chambers of commerce. It's, the faith-based community is there. I mean, everybody is a part of this. And so we convene and develop the vision and plan based on the appreciative inquiry of how we can help a community to be healthier, to be better response, more responsive to the individuals in our community, and move forward. And then we leverage those resources to support them locally. And the work that goes behind this is that it has to be continuous. You can't just set it up and assume that it's done. We're good. We've got our relationships. We can go from there. You have to really build on the community and continuously meet and talk about how it's working, what's not working, what changes need to be changed or to be made. Using rapid adaptive logic in everything you do, which means that you come up with an issue, you design the resolution to it, and you enact it. So it's a very enacting focus on, again, time critical on achieving results in your community that are going to help the individuals that you're serving. So this is, again, a constant. It's a lot of work. My organization, it was when I first started doing this, it was just me, and now I have a whole team of staff that are helping to maintain these relationships and continue to build on the assets of the community. The other mapping we do is the sequential intercept mapping, which many of you may be familiar with. When we first started doing it, it was intercept 1 through 5, and through our work with the Gaines Center, we figured out that, well, there really needs to be an intercept 0, and so the intercept 0 was introduced, and that's the community services, the crisis care continuum, the crisis lines that are created, and then it moves into, unfortunately, the 911. The intercept 1 is local law enforcement, but what we've done with our mapping is we've looked at the gaps, and then we've engaged in each of those intercepts so that we can make it a better outcome and a better experience for the people that we're talking about that go through the criminal justice system. And through each intercept, we have filled particular gaps. A lot of those gaps have been filled by the mobile team. A lot have been filled by the stabilization center. But getting back to the mobile team, it's really been the mobile team going to intercept 2, which is the initial court hearings and the initial detention. Intercept 3 they're involved in, which is the jails and the courts. Intercept 4, they can get engaged again through the work we've done in the jail reentry system, where they can help them to transition back into the community. And then intercept 5, it's the parole and probation that the mobile team can still be involved in, but we also use our other services in the organization with the peer services, the housing, and other services to help them to be successful on parole or probation, whatever it is they're involved with. So these are the different intercepts that we've worked to achieve, filling gaps in the criminal justice world so that people can avoid it in the future. And then getting back to the other mobile teams, working on avoiding even any entry into the criminal justice system has been helpful. Even though we have very close relationships with the police departments, we're still avoiding this whole, intercept system. by heading it off before crisis actually even occurs. So that's the goal of our mobile teams. So here's some of the outcomes and cost avoidance that we see in our services, which are, again, also tied into all our mobile teams and the work we do. But Rose House examples of we've diverted in 2022 265 guests, at 5 days. 50% are mental health hospitalizations usually. So we're saving 212,000 on ER visits. And if you look at the total savings or cost avoidance is what we call it, it's over $1 million in 2022 for just one house. So we have 4 houses, so you can see that it's well over $4 million, or $4.5 million of savings a year. The stabilization center, it's similar. It's jail diversions as well, because the CIT officers that are trained will bring people to the stabilization center rather than have arrest. And you can see in 2022, we had 163 drop-offs. 50% were incarcerated with average costs. If 50% were incarcerated, average cost is $20,311. Total cost and savings there was $1,655,000 for the stabilization center work. And then the mobile team, we have outcomes showing a 98.2 success rate of court appearances converted to alternatives to incarceration. So again, a large savings there. And just so people are aware, we've now invested in research so that we can research the variables even better to see what the savings are, but also what the outcomes are for the individual. It's easy to measure the ATI. It's easy to measure the cost of avoiding, jails or hospitals or emergency rooms or whatever. But we also want to measure the quality of life and any changes that we're seeing in the services that we're providing. So we've started the research on the stabilization center. It's then going to move into the diversion houses and the mobile teams to measure those as well. So that's coming, in the next year. We'll be doing more of that research. So with that, this is recording, so I can't take any questions, but you can contact me. And I believe my information is going to be given to you on how to contact me if you have any questions, and I'll be glad to answer those. So thank you very much for listening. It was great to be a part of this, and I wish you all well. Thank you.